Welcome to Lunch Break, Podcast 3, Cost Efficiency as a Weapon. Welcome back to Lunch Break for Nurses. Let's talk about the things you don't get to discuss at work. Bullying, unvaccinated patients, salaries, politics, your money. These are the topics you would talk about at lunch, if you ever got to take a lunch break. Hospitals use cost efficiency as a weapon, not in the sense of deliberately harming patients, but as a survival strategy. In an environment where reimbursements are often below the actual cost of providing care, and margins are razor thin, the average U.S. hospital operating margin has hovered between 1% and plus 2%. When cost efficiency becomes the dominant priority, it can function like a weapon turned inward against staff, against quality, and sometimes against patients. Staffing to the bone, the real weapon. Hospitals use sophisticated staffing matrices and productivity targets that are benchmarked against national averages or the top quartile of similar hospitals. Nursing ratios are kept as low as legally or contractually possible. These usually stay the same even when acuity is high. This results in higher nurse burnout, more medical errors, higher hospital-acquired infection rates, and higher 30-day readmissions, all of which paradoxically increase costs later, but the short-term labor savings show up immediately on the monthly profit and loss statements. Supply cost aggression. Hospitals join giant group purchasing organizations, GPOs, that demand 20–40% price reductions from vendors and switch to the cheapest equivalent product. Sometimes these are not as user-friendly for staff. Physicians lose preference items, for example, a specific hip implant or cardiac stent they trust, and are forced onto the value alternative. This is literally called Physician Preference Item, PPI, cost reduction in board presentations. Extreme version. Hospitals begin reprocessing single-use devices, SUDs, such as electrophysiology catheters or harmonic scalpels. Denial management and underpayment recovery as a fence. Hospitals build large revenue cycle teams whose sole job is to fight insurance denials and takebacks. This is framed internally as cost efficiency because every recovered dollar is pure margin. Some systems use AI-driven tools to automatically appeal every denial, even low-dollar ones, turning patient billing into a war of attrition against payers. Length of stay, LOS, reduction as a blunt instrument. Daily huddle, prioritize length of stay over quality. Case managers and hospitalists are given LOS targets. Bonuses and even continued employment can hinge on hitting them. As a result, patients discharged quicker and sicker, higher readmission rates. CMS then penalizes hospitals for this, creating a vicious cycle. Service line pruning. Unprofitable service lines. Like obstetrics in rural hospitals, burn units, level I trauma centers, behavioral health, and pediatrics are closed because they lose money. One hospital becomes more efficient on paper, but the community loses access to specialty care, and sicker patients are transferred out to academic medical centers who bear the cost burden. Wage suppression. Hospitals try to replace RNs with LPNs or unlicensed assistive personnel wherever possible, especially in clinic settings. They use travelers only as a last resort, they cost 2-4 times a staff nurse. Then blame schedule holes on labor shortages while refusing to raise base wages to market rate. Observation status gaming. Admitting patients under observation, rather than inpatient status, avoids DRG payment cuts and RAC audits, even when the patient objectively meets inpatient criteria. Cheaper for Medicare, but shifts costs to the patient. Part B copays, no SNF coverage. In short, cost efficiency is a weapon because the financial structure of U.S. healthcare incentivizes hospitals to extract every possible dollar while spending as little as possible, regardless of the collateral damage to workforce morale, care quality, or long-term outcomes. The hospital that refuses to wield this weapon aggressively often goes bankrupt or gets acquired. The ones that wield it most ruthlessly, HCA, tend to generate the highest earning, EBITDA margins, until a whistleblower lawsuit, a pandemic, or a private equity collapse catches up with them. It's not evil people making evil choices. It's rational actors responding to a reimbursement system that pays by volume or bundled payment while costs rise faster than inflation. Cost efficiency just happens to be the only weapon most hospitals still have. You've been listening to Lunch Break. Drop a comment on this video to let us know your thoughts on this controversial topic, and don't forget to subscribe. We care about you. We care about you.